Good afternoon, everybody, and happy Friday. Welcome to the COVID Weekly Roundup for California Association of Health Facilities. Today's April 24th, 2020. We're going to discuss some of the AFLs that came out this week, including one that just was released this morning, and we'll cover the differences between that and the previous version of the same AFL in a second here. Along with me today is Stan Spiddick. Stan is the president of Fire Life Safety, Inc. Many of you guys know Stan as well. Stan is the CAF Life Safety Code consultant. That's Stan's contact information there at the bottom of the thing. Just as a reminder for you guys, as you have questions, especially during this event where I'm kind of pulled in multiple directions, if you have life safety code questions that need to be answered about, a bunch of different things. During this time, I highly encourage you to proactively reach out to him with any questions if you need them. Okay, so we'll go on to the first update. And I know I talked to you guys last week about the daily reporting requirement. That's now, there's an AFL that describes all of the process. I'm certain that you guys are all familiar with this. We've heard from some local district offices that they're still doing the phone calls as well as doing the online survey. But at the end of this week, once they've worked out the kinks and they know that the surveys are being completed, then they'll stop doing the calls so we can do that. I also spoke to the MOACs for a couple of different counties to ask if CDPH was sharing this information with the folks at the county level that would be responsible for providing us help or resources in the form of staffing or PPE. Were they getting that information in a timely manner? And it seems like they're getting the information in about a 24-hour delay, but at least CDPH is using this information to help the local jurisdictions determine planning objectives and to see who is most at risk. I will say that I kind of feel like a heel in that I asked everybody to start doing these things with the assumption that this would give us an immediate access to those staffing resources. And unfortunately, I don't think we can clear that bureaucratic hurdle. So they've issued another AFL as it relates to immediate staffing needs, and I'll cover that in a second. And I just wanted to talk to you about SNF assessment checklists. They were kind of buried like a fifth attachment on another AFL that went out. But if you'd like a copy of what CDPH is looking for you to be able to provide safe care in either a transitional space for suspected COVID positive people or COVID positive people. And then AHCA has also done their own self-assessment checklist that you can download. Both of them are very thorough checklists and will help you walk through the process of setting up those spaces in your building. All right, so infection control surveys, we know these will continue to happen. We also know that we've been told that there have been a number of instances where the same survey team has come back and revisited a facility 2 or 3 weeks after the initial survey. And this wasn't as a result of anything that they had identified on the survey. It was just them following up to make sure that the facility was prepared. I always, try to read into why those folks continue to come, and I'm skeptical for their reason for coming. But I just want to make you guys aware of this, that just because you've got one infection control survey does not mean that you might not get another one very soon after that. And then we had another question: are the surveyors allowed to enter the facility? And we know a number of providers that have out refused surveyors to come into the facility if they had previously been in a facility with a COVID outbreak. And I just want to let you know, CMS has addressed this in their guidance. It says we're not supposed to do that, but it assumes that that the survey staff are effectively wearing PPE according to the CDC guidelines. We can't verify that, so I understand that there's a concern if you have somebody come from a COVID positive facility into a skilled nursing facility or go from one to the other. It's definitely a vector for the, for the disease to get into our buildings. So I think my suggestion is this is one of those areas where you have to work with the surveyor and try to help them understand that the risk this could pose. We can't guarantee that they effectively use PPE in the previous building, and we would just like, is there alternatives to how this do that? Can I take a phone in there into my building? Can I do this by FaceTime or Skype? Or what elements of the survey can be done without you in my building? Can we do it in the parking lot? Can we do it under a canopy? Can we do it somewhere else? I think as long as you work with them, the initial conversations I'm hearing seem to be that the surveyors understand that perspective. Are we going to have surveyors that say, listen, I have authority to go in your building regardless of what you say? Of course, we're going to have those folks. I just want you to just work with them, be collaborative, ask them like, hey, this is a real risk to our folks, so let's do it in the smartest way possible. I think they're very understanding of that, even though CMS has said that they're allowed to go into the building. All right, so many of you guys have heard the term alternate care sites, and we'll talk about kind of the plan of how alternate care sites have been adapted and how they're planning to be used now. Alternate care sites are generally a function of a government agency where they would be set up and staffed and run and managed by a government entity. In these instances, the first two examples there, Fairview Developmental Center and Arco Arena, both follow that model. But in these models, the Fairview and Arco Arena model, they have dedicated space specifically for post-acute care or skilled nursing residents. Now, there are limitations on who they can take, and each alternate care site gets to determine the capability or the types of patients that they can take. And so it's encouraged that if for some reason, let's say you have an outbreak and you have a huge problem with staffing, and we cannot get staffing there to support the operations, and you're close to one of these two sites. So there's a whole bunch of things you got to get to before you get to this. We don't want to evacuate facilities. That is not at all what anybody wants, not what skilled nursing facilities want. That's not what the counties want. That's not what the state wants. And it's certainly not the best in the best interest of the residents in the building. So first, we want to avoid that if at all possible. But if we do need to send folks to the alternate care sites, what is supposed to happen is your medical director would call the medical director of the alternate care site to go over the cases in which the alternate care site would be likely to take. And then through that discussion, you'll be able to determine which one of your residents could go to that alternate care site. Then the local health department would be responsible for coordinating that movement from your facility to the alternate care site. You would then be responsible for holding that bed while that person was at the alternate care site until they no longer needed to be at the alternate care site. In most of these cases, it's going to be as a result of staffing, because we could have 30 or 40 or 50 staff turn positive if we go test a building. And so those are the kind of the situations we're thinking of. So those patients, hopefully they don't decompensate. They're gonna pass this virus and they're gonna be okay. They're gonna have to have a spot to come back. And the goal is, once your staffing is back in the building after they have passed the virus in the contagious stage, they can come back to work. And at first we would put them to work with the COVID positive patients that were coming back from the alternate care sites. That's kind of the model of how the alternate care site would work, but there are very severe limitations on who they can take. So I wouldn't count on that as being a first resort. This is a last resort, and even at that point, there are going to be folks that these alternate care sites can take. Folks with severe dementia or cognitive abilities, those folks are not going to do well at an alternate care site, and frankly, they're not equipped to deal with them. We have asked them to increase the acuity in which they can take these folks. But I think this is a no-go with the type of residents they can take. We have worked with them on expanding the scope into not requiring, the first initial kind of guidelines followed more of an assisted living resident than it would be a skilled resident. And we've worked with them to kind of expand that. And it's got to the point where your medical director is going to have to talk to the medical director of the alternate care site to determine whether the alternate care site has appropriate care for that resident. And then I wanted to talk about alternate care sites as it relates to us. Could we set up our own alternate care sites? Hospitals have done this before, and they are currently doing it to meet surge needs here. But I just want to talk about it in context of the spaces that we have. Many of our members are part of a CCRC, and for you guys, you have larger campuses which have space within the campus that you may be able to designate as a COVID positive space. And those are models that are being developed and being approved by CDPH and DSS across the state. This would be a good model, but the model really has to follow those kind of the guidelines for cohorting. If you're going to set up a space on your facility, it doesn't matter. I mean, it helps if it's a traditional, you have a bedroom and a bathroom and all that other stuff. But that's not, it doesn't have to be exclusive to that. It can be other space. But all of where the beds are, where the bathrooms are, how you're going to get food to them, where the storage is, where the clean storage is, where the dirty storage is, all of those things have to be planned for in your alternate care site. If you're looking at how to set up a model to do that in your facility, I'm happy to give you other plans from other providers that have done this, as well as look at what CDPH wants from alternate care sites. But it's a model that, if you have the capacity, is probably a best practice, because if you have a separate building where you can provide patient care, that in itself is much safer to the existing residents in either a skilled nursing facility or an assisted living facility. So it can be done. If you guys are thinking about doing it and have capacity to do it, I'd love to talk to you about it or connect you with other providers that are currently doing that. The reason why we harp on these alternate care sites and things like cohorting, and I want you guys to understand that this is a long-term, this is something that's going to be affecting us for the long term. And if you're a provider hoping that enough people raise their hands so that you don't have to be one of the facilities that has COVID in it, I don't know that that's a realistic option. Our projections is this is going to be a long-term issue for all of the skilled nursing facilities in the state for at minimum the next 9 months. This is something that we're going to have to deal with constantly until we can test every single person that gets discharged from a hospital or a SNF, and until we can test everybody that goes out for something, and when they come back into the building, we cannot unequivocally say that we're getting negative people into our building. So we have to have a space to be able to deal with these folks that we cannot identify whether they're positive or negative. So when we talk about transitional space, I'm not even talking about taking COVID positive people into your building. I'm talking about taking normal discharges into your building that you don't know whether they're positive and negative. Those are the cases where we've identified more than a dozen facilities that have had outbreaks, have had it because of a resident or a patient coming from another level of care into our level of care non-tested. And so now we know we've got to treat those folks with precautions. We know we're going to assume or we're going to observe those folks for 14 days, and we're going to keep them isolated to the extent we can within our existing physical plan. All of that stuff needs to happen. The great thing, though, is if you set that space up and you treat every discharge like that, you now have a space for COVID positive residents if one of those folks spikes a fever or develops symptoms. You already have them in a space that you have identified with being able to care for them, because the transitional space and the COVID space are going to look very, very similar. So I know there are folks that are thinking, gosh, I just hope nobody calls on me, and I hope this passes me by. But I don't know that that's a great plan to hope that this is not going to happen. So if you're waiting to design or designate that space, please don't do that. At least designate a transitional space to observe these folks. I think that's best practice. We obviously need to keep on our staff. That's a huge vector for where this comes into our buildings. We've got to stay consistent on that for sure. But the transitional space, I think, will help us and will also build you capacity for when one or two or more of these people become COVID positive. So it's important to look at all of that stuff when it comes to cohorting these folks or developing spaces that we can deal with them in our buildings. All right, so I talked a little bit about the emergency staffing earlier. The MOOC is still the point of contact for emergency staffing requests. If you're not familiar with how this works, it works the same way that you request PPE from your MOOC. The form is the same. There's sections for staff stuff or supplies. You're going to be asking for staff. You're going to give them specifics. You know, what type of licensed staff do you need? What type of care worker do you need? Be as specific as possible. They may not have the resources to meet your needs, and frankly, they probably won't. But at least then the goal is to immediately identify statewide resources that can be deployed directly to you. And this is happening in a number of facilities up and down the state. You've heard the stories of the CalMat or National Guard teams going into healthcare facilities. That is currently happening in multiple facilities. And if it does happen to you, or you have to reach out for whatever reason for staffing resources, I don't want you to feel like this is your fault. Some of it is self-inflicted, but there's so much of this that moves without your control. What is in your control is to understand that you should probably have a good list of nursing registries if you don't already. Have an idea of whether they have staff and how quickly they can get them to you. The MOOCs are going to go, you're a business. We expect you to be self-sufficient first, and we will be the backstop if you can't access those private resources. So we've got to continue to do that. We've got to understand where we can get those staffing resources ourselves. And then once those have been expired and we can't do anything, and we've switched our staffing models to 12 hours or whatever could work, and we stretch people out and work them double shifts and all that other stuff, that's when the MOOC says, we can send you staff. Now, in areas of the county, what our plan is to develop a playbook when the MOOC can't meet your needs immediately. So many of you guys have seen situations like the facility in Riverside. There are other facilities that have real similar staffing crises. And when that happens, the facility reaches out to the MOOC, they go through their process. The MOOC says, I don't have anything locally that I can send to you. I have to make a request to the state. Now, generally, it takes time for those resources to get deployed. So what us and the Hospital Association and Leading Age, and to some extent public health, have done is to develop a playbook which would work as a backstop. If the local MOOC could not fulfill those needs, where we could enter into a mutual aid agreement with a local hospital to have services provided. Now, those services won't be free, they'll be at a cost. That's written into the mutual aid agreement, but this is a voluntary thing that you could do. And especially for communities like that are less urban, where you could have much less access to staffing resources. The staffing resources, I'll give you an example, like Tulare, not a lot of staff sitting around waiting to be deployed to that nursing home that needed help. So the county reached out to the hospital and said, hey, can you help? And in some areas, that will be the only method of getting immediate help to the facility. That's not what we want, but we want to do that even less than we want to evacuate folks, or even more than we want to evacuate folks. We want to evacuate folks as a last resort. And especially if those folks are going to be evacuated to a hospital, the hospitals go, hey, look, maybe we can get out front of this and help these providers. The playbook that we worked on has an infection control component so that you could be supported to make sure that the infection control needs would be met. But the whole goal of the playbook is to basically stop the flow of, stop the bleeding and get in there and stabilize you guys so you can be self-sufficient and not have to use any of the resources from the county or the hospital. That should be finished today. I want to say that this is something that the Hospital Association, CAF, and Leading Age put together. CDPH only brought us together. They're not involved in the development of this, although we will send it to them for at least have them take a look at it. But I want you to know there are compromises with all of us, with the hospitals here, with us, with Leading Age, with CDPH, with the MOACs. We all have to pitch in a little bit more for this. But I think it's a good, well thought out plan. And if you find yourself in a crisis, this may be the only way to get you out of it and keep your building open. So we will release that on our website, and we'll send it out as a magnet mail, and we'll probably put it on the forums as well as soon as we're completed with it. All right. So that was the first 22 minutes. I want to give the next 22 minutes to my good friend Stan. Many of you guys know Stan. Stan's got some great feedback on the life safety code stuff, because I've had dozens and dozens of providers ask me, what am I supposed to do with my life safety code requirements while this is going on? So I asked Stan to come on. He's going to give us a brief description of that stuff, and then we'll answer some questions at the end. Stan?
Well, thanks, Jason. I'm really proud to be part of this organization and the great work that you and Courtney and the rest of the team in the office are doing to provide our members and those that are covered by the grant in the state and in Los Angeles County with the resources that we've all been working with. And one of the things that comes to mind, and one of the areas that has been taking up a lot of my time, is I'm sequestered here in sunny Phoenix, Arizona, where the temperature is 94 right now. So we're hoping those UV rays and that sunlight's going to kill that dreaded disease, but that's besides the point. The reality is there are a lot of life safety considerations and consequences that are coming up during the management of COVID-19. And in my capacity as CAF's consultant, and also working in a similar capacity here in Arizona with the Arizona Healthcare Association, my phone rings pretty steadily about some common issues and common concerns that providers are having during this time. So I wanted to take the time and go through a few of these things. Courtney is standing by to field your questions. If there's one thing that we're hoping for today, if you do have a question for the good of the group and the good of the call, please make sure that you express it in the chat box, and she'll get me that information. If you've got individual questions or concerns, my role with CAF is to support our members with their life safety questions. So you'll see my contact information again. It was just the other day that I got a call from a provider, and he was panicked, and he said, what about fire drills? Dan, I'm having a real problem meeting my monthly fire drill requirement. Many of you on the call that come to Jason's and my annual presentations in Palm Springs on life safety knows that there isn't a monthly fire drill requirement. You know, it's funny, we do get conditioned, we do get into the practice of performing our required fire drills on a monthly basis, but everybody on the call should know that CMS, as enforcing the Life Safety Code, NFPA 101, the 2012 edition, knows that you're required to do a fire drill per shift per quarter. One fire drill per shift per quarter. Regardless of if it's your community's or your facility's practice to do the first shift, the first month of the quarter, the second shift, the second month, and the third, that's not the requirement. So here's your strategy. Here's your workaround for the management of COVID-19 and life safety considerations, particularly when it comes to fire drills. Push all of your fire drills back to the end of the second quarter. Of course, we just started the second quarter. That means you've got until June 30th to do all of your fire drills. And yes, if you choose to, you can do all of your fire drills on one day. And if that day is June 30th, you're going to still satisfy the requirement if you're following a calendar year quarterly schedule. But the thing about your fire drills, and you already know this, your drills cannot be scheduled. They've got to be random. They can't be predictable. But in these challenging times, if you defer your fire drills to the last part of the quarter, you're going to be able to alleviate some of that stress that some of our administrators and others are concerned with. And yet there's even more good news. For those of you that have been around the block for a while, you know that when you conduct a fire drill after 9 p.m. and before 6 a.m. in the morning, so the latter part of your second shift and during your knock shift, if you conduct a drill between 9 p.m. and 6 a.m., you know that that can be a silent fire drill. You know, one of the other things that I can't give you a complete and accurate viewpoint on at this point, and Jason, I'm wondering if you've had any experience with this, so get ready to tap in. I'm hearing that some of our members in California are doing virtual fire drills. They're using technology, they're using video. And Jason, what do you think, how do you think the surveyor is going to accept or view a drill that was done virtually? Because personally, I haven't had any experience with that.
Yeah, and to be honest with you, this is the first I've heard of it. If that's what you're doing, at a minimum, you have to write that into your policies and procedures for fire drills. So you would have to amend your current policies and procedures to add that in there, the language in there that said, in the event of a emergency or a pandemic, or however you want to term it, I would say you at a minimum you'd need language in your own plan to identify that that's how you're going to accomplish it.
Boy, it almost sounds like we know what we're doing here, Jason, because that's my second point. If you are not going to be able to be within the strict compliance, the letter of the law, the letter of the regulation, when it comes to compliance with NFPA 101, the Life Safety Code 2012 edition, or NFPA 99, the Healthcare Facilities Code 2012 edition, you do want to and you need to make modifications either to your EOP, your Emergency Operation Plan, or your associated policies and procedures that acknowledges those changes. You might want to make an addendum to your EOP that says something like this. During a declared emergency where our EOP has been activated and in the midst of an infectious disease outbreak, certain elements of the Life Safety Code may not be able to be complied with in the strictest form of compliance. I'm just pulling that out of the air. You want to be as specific as possible. We don't know how surveyors are going to react to some of the audibles that have been called, like a virtual fire drill. But what we do know is that if you do attempt to mitigate any change in practice when it comes to Life Safety Code compliance, you need to modify policies and procedures. You need to make addendums or modifications to your EOP to acknowledge those life safety changes. And Jason, we haven't had any 1135 waivers issued specifically for Life Safety Code compliance, but why don't you talk real briefly about the submission that you made to California? I know that here in Arizona, we've also, as association, made some application for 1135 waivers. What are some of the things that we're looking to waive?
Well, let me see if make sure. Oh, there we go. Okay. Um, we submitted a request to waive some of those, the annual drill requirements, the annual exercise requirements for the EP rule. Um, it it was pretty lengthy. I'd have to give you like the list of all of the things that we've identified, but in my, at least from what we've seen, that this has not been a focus for CMS. Certainly, they want to address the 1135 waivers for more of the other stuff that has to do with directly with patient care, and they've not really addressed this for any state that I've seen. I've not seen them waive this for any state yet. If they do, what I'll do is just copy what other states have done to get their approval and ask for that. But we have submitted the waiver and we were denied. We submitted the waiver, another waiver again with the life safety code information on it, and we have not received word whether that's approved yet. So
Very good. You know, I mean, I hope you're hearing what the message is here. The rules are the rules. You've heard me speak many times about compliance for compliance sake. The reality is we know that a life safety compliant facility is going to be a safe facility. And yes, you've got some oppressive rules that you're trying to deal with in the midst of your battle against an infectious disease. But let's try to navigate a little bit more of this as we go through. Specifically, one of the things that I know that Jason had me review was some language regarding inspection, testing, and maintenance of your fire protection and life safety systems. You know, if an annual is due, a quarterly, or something else where potentially you need to have a vendor in your building, I can just tell you what my experience has been. And that experience is that about 50% of the time, a provider like you on the call today will let a vendor in the building if he or she's been properly screened. And the other half of the time, they're saying, nope, we're not going to do that. You know, I don't want to get really down into the weeds, but we still have some time here. You know, a lot of you call me up or send me an email and say, what exactly do they mean by the definition of quarterly or semi-annually? Well, this is straight out of NFPA 72, which provides some pretty prescriptive language on frequency. And I hope this is going to be a benefit to you on the call today. So weekly means 52 times per year, once per calendar week. What needs to be done weekly? Well, one thing that pops to my mind is that you need to do a weekly cleaning of your commercial kitchen hood and associated appliances. Monthly means 12 times per year, once per calendar month. Quarterly means 4 times per year with a minimum of 2 months and a maximum of 4 months. Semi-annual means twice per year with a minimum of 4 months and a maximum of 8 months. And annual means once per year with a minimum of 9 months and a maximum of 15 months. Now, I think the conjecture could be made that, you know what, we're under the gun. We're fighting a battle. Are they going to really be focused on strict compliance? Hey, Jason, I think my impression is, and it was kind of fortified by yours and my conversation about this, until we hear otherwise, the expectation is they're going to have to adhere to these regulations. Any thoughts about that?
yeah, I think you're absolutely right, and your advice to add an addendum or language on their EOP that prescribes how you're going to accomplish that, or what other method it is. I think that's your best chance of being able to avoid some of this stuff. But if we rely on a surveyor using common sense to go, oh, hey, you were, dealing with COVID during that time, I understand why you didn't keep good records. I wouldn't count on that happening. I'm just not optimistic. So I would CYA, make sure that you're doing it to the extent you possibly can.
Yeah, I would agree. I'm saying this with all due respect because I know that the intention from an administrator or a maintenance director or an environmental services director is advocacy and protection of their patients and staff. But I use the term loosely. I've heard some pretty cavalier statements being made where somebody might say, you know what, I'm just going to take my chances. If I get the hit, I'm going to get the hit, and I'll take the deficiency if we miss a fire drill, if we fail to do a generator test. It's our impression, and I've confirmed this with some of my colleagues around the country, that the expectation is that you need to focus more on life safety now than ever before. You're sheltering in place. You might get that miraculous delivery of PPE, and all of a sudden you're going to be obstructing exits. You're going to be using spaces that aren't designed to be a storage room as a storage room. You need to do those drills. You need to maintain that culture of safety and preparedness. And we speculate that the attitude of the surveyor, if you willfully and wantonly say we disregarded something reference to compliance without an 1135 waiver or modification to your plan or policies and procedures, we speculate that they might look at that as immediate jeopardy, possibly with CMP, CMP fines imposed, and even, an impact to your 5-star. So CYA, like Jason says, and don't let the need overshadow the safe practices. I remember was a couple of years ago, and COVID wasn't even in our vernacular, but there was an infectious disease outbreak in one of my client facilities in northern Arizona. And right out of the box, I walked into the facility, and it hit me right in the face that somebody had overpopulated the hallway with an abundance of alcohol-based hand rub solution dispensers. They clearly had some kind of virus or something happening in the building. Maybe it was norovirus or something. And the solution was just to put as many ABHR as possible. There's specific limit to the amount of solution that you can have in any particular smoke compartment. That number is 10 gallons in aggregate. But here's some good news. The aggregate only includes the amount of solution that's within the means of egress or common areas. If you've got a hand rub solution station, a dispenser in your residence room, you're allowed to have one in your room with no more than 1.7 liters per unit, but the volume that's in your resident rooms or other protected areas doesn't have to count towards that 10-gallon aggregate. The concentration of ABHR is up to 95%. So you've got a flammable liquid in your environment of care. You've got to be careful about installing them away from ignition sources. NFPA 101 says you have to be 1 inch away. You shouldn't be above an outlet or near a switch. And if you're going to store any of that solution in bulk, you're limited to 5 gallons per smoke compartment. So if you've got specific questions about that, you can contact me. Back to general storage, the need might come up that you've got a resident room that you need to convert into a storage room. It might not have a door with a self-closer. It might not be a 1-hour enclosure, but back to our overwhelming theme here, if you modify your policies and procedures and state that you might have to use a residence room for storage of an influx of new supplies and stuff like that, you're going to be able to do it. Of course, be mindful of common storage practices, 18 inches below the bottom deflector of the sprinkler head. Make sure that you've got aisles that will allow people to get out, and just use common sense when it comes to storage. The same theme is true for the means of egress. What is the need that arises? Maybe you're setting up a screening station at your point of entry into your care center, and that includes a table and maybe some equipment and some supplies and so forth. If I walk into your building under the auspices of a mock survey, like many of you engage me to do, and I see that obstructed or compromised means of egress, or if a surveyor sees that in the midst of a complaint survey or at any point being in your building, or maybe there's just a resourceful off-duty fireman that sees that your hallway has become an obstacle course with supplies and equipment, you've got to remember that means of egress is the most important passive element of fire safety in your building. You've got to keep your hallways clear. Anybody on the line that's had any firefighting experience like Jason and I, you know that is your lifeline in and out of the building. And while in an emergency or while in a non-emergency situation, what's the difference? But you need to write into your plan that if you've got isolation carts, if you've got items in the hallway, that you've got to remove those when the alarm sounds, when there's a condition of smoke or fire in the building, so that you keep your path out of the building open and free at all times. You know, I get a lot of calls, and I'm not an engineer. A lot of it is things that I need to refer to other people. In the last two bullet points are two items that are representative of this. A lot of questions about setting up temporary barriers, isolation rooms. Can we just put visqueen over our smoke or fire doors? Well, the answer to that is no, because that would compromise the function of the smoke or fire door. But using some reasonable measures along with alternate life safety measures, a plan, a training requirement to segregate your building in a common sense way is something that's going to be considered as potentially safe as long as it's not safe, or as long as it's not a condition that's not safe, and that you write it into your policy and procedure and you develop an alternate life safety measure. One of the things that's coming to mind is that sometimes when you do a renovation project in your building, you do some demolition or remodeling, your construction crew sets up a temporary barrier. You develop an ALSM to accommodate that temporary condition. Jason, I don't know about you, but we're seeing some parallels to this. You know, some people are putting up plastic. There's a zipper opening. There's a door built in. And then there's also the question of negative pressurization. Jason, we know for sure that there is no requirement for negative pressurization as an accommodation to fight COVID-19. Is that correct?
That's correct. Well, that's the current guidance. You know, as this has gone along, we've changed guidance. It started, you know, as an airborne thing, and it went to a droplet thing. And if you're going to be doing procedures that create aerosolized exposure, then those procedures need to be done in negative pressure isolation. And that generally those procedures are done at the hospital. But as you think about how you might have to treat this person, when you're looking at a discharge from a hospital, look at those therapies or things that they need that could increase the risk of airborne infection. And for those folks, those are the ones, if you don't have negative pressure isolation, you're not, the current guidance is to not do those procedures unless you have the negative pressure isolation. I'll go on to say that most of the guidance from CDC as it relates to cohorting or designating a wing or any of that other stuff talks about when you set the wing up, you want the wing to represent an entire run on the HVAC system so that the exhaust for those rooms is not exhausting into a break room for your staff or something like that. So it makes it much more difficult to think about it, but it's something that you need to do in conjunction with your physical plant staff to understand where those rooms can be set up.
Yep. Boy, that's some great perspective. You know, the general rule is, Jason, I think you can move on to the next slide with my contact information as we get ready for some Q&A. If it looks unsafe, it's probably going to be unsafe. And, you know, I've seen some pretty nifty temporary partitions that were put up. They're not permanently affixed to the hallway. They're using some tension or pressure to affix a frame to the hallway, you know, kind of visualize an 8-foot wide corridor. There's a nice door inside of a frame with some plastic with an exit sign. If access to a fire extinguisher might be compromised by the presence of that, a fire extinguisher is temporarily installed on the other side and so forth. So there's a lot of creativity that you can do, and we're here to provide some consultative assistance if you need anything specific. So with that, Courtney, do we have any specific questions that we can answer?
All right, I think that's about the end of the questions. I just want to remind folks that we have a website that deals with for nothing but coronavirus. It's updated as we get updates. I mentioned there was an AFL that came out a couple hours ago, AFL 20-30- or .1. It doesn't look that different from the previous versions of this AFL. There were some recommendations of setting up those transitional spaces, but if we notice any real big material changes, we'll post that on the forum, but it looks pretty much the same as it has been. So I want to thank you guys for your time. I hope you have a nice, relaxing weekend. You can do some stuff that's not, coronavirus related, and don't hesitate to reach out to Stan, myself, or Courtney with any questions. Thanks very much, guys, and have a great day.
See ya.